So the speakers for our next session will be Ms. Rana Bayakli, Dr. Maggie Miller, and Dr. Bernie Schurz. Ms. Bayakli is the Chief Epidemiologist at the Georgia Department of Public Health, Chronic Disease, Health Behaviors, and Injury Epidemiology Section. She is the Principal Investigator for the Georgia Violent Death Reporting System and currently holds the position of Director of the Georgia Comprehensive Cancer Registry. Dr. Miller is a Research Assistant Professor in the Department of Epidemiology and Biostatistics and the Alzheimer's Disease Registry Manager for the Office for the Study of Aging in the Arnold School of Public Health at the University of South Carolina. Dr. Schurz is a professor in the School of Medicine in the Department of Neuroscience and Rockefeller Neuroscience Institute at West Virginia University. He is the director of the West Virginia Alzheimer's Disease Registry. And today, our speakers will lead our second session entitled Introduction to Statewide Alzheimer's Disease Registries. Rana, you can go ahead and share your screen.
Good morning. Can you see my screen?
Yes, perfect. Thank you.
And it's in a presentation mode. Is that correct?
Yes, it is.
Thank you so much. And thank you, Dr. Thorpe, for your presentation. It was really excellent. And I will take your help anytime. And thank you for offering. All right, let's see how to move this forward. Here we go. All right, I'm just gonna give you a background of our Alzheimer and related dementia registry in the state of Georgia, provide with some information related to the various databases that we have, and give you some sample data that we have analyzed and shared with our policymaker, our program partners, and our research. So overall, our registry is new compared to the other registry in South Carolina and West Virginia, and we actually learned from them when we were establishing our registry. It was in 2013 when the General Assembly established a task force that we refer to as GARD, their multidisciplinary task force with members that representing government, private organizations, as well as the public. They recommended to have a central registry. And in 2014, our legislator passed a law creating the central registry and placed the registry within the Georgia Department of Public Health. And rarely, but in this occasion, we were glad to say that it was funded at $110,000 per year. And to date, we still receive an annual budget of $110,000 from the state. Our purpose, as it says in the law, is to create a central registry within the Department of Public Health. And we were tasked to create rules and regulations related to the registry. We are to produce prevalence, and we are to share our data with policy makers and our programs and various stakeholders that are participant in our GARD group, as well as share data with researchers so that it help in doing further research and to keep the data confidential. So as any public health surveillance system, the data is always kept confidential and data are shared when it is approved through an IRB. Our commissioner at that time in 2014 was very keen on us creating a quick portal for physicians to report Alzheimer data information. So we created this portal on our state grown system that we call SENS, and that stands for State Electronic Notifiable Disease Surveillance System. It is confidential and only users can access the portal through a password, create a system, create an access and have a password to enter the data in, but it is for physician to report. It does have data element related to the physician themselves who reported the disease or the case, the patients, some information on the disease itself, what it is, how far or what the stage it is diagnosed at, some treatment information, as well as some comorbidities and exposure, such as tobacco, alcohol use, and toxins, as well as occupation and industry. After we created the database and made it live in 2014, we've decided as the Department of Public Health and the EPI department is that to really work on another mechanism for reporting. As we understood, physicians are not very strong in reporting, especially if they have to go to a place to enter this information. So we've decided to do some tests on reporting from physicians or clinics using their electronic health record. So we created an HL7 message for Alzheimer disease and dementia and other related dementia. And we use the same data elements that we have on the portal in creating that message. And we work with our Georgia Memory Net, which is a statewide program. And it is in partnership between the Department of Aging or Division of Aging and Emory University to help us working with the memory assessment clinics, that they are 5 of them, to implement the HL7 within each of those clinics' electronic health record. We decided to go with these clinics because of the fact that the Georgia Memory Net, one of their tasks is to continuously training a physician on how to early diagnose, and how to provide appropriate treatment for patients. With the money we had, we're not able to really do the training. And as you collect data, you really needed to collect data in a very standardized way. And having Emory involved with us from the very beginning help in having that standard among these clinics. So we kind of focused on only these 5 clinics reporting to us. We started piloting or testing with each clinic starting in April of 2020. And we were able to go live as of January 1st, 2021. And as you can see, from January to April of 2021, we have collected almost 33,000 cases. And if you project this for the rest of the year, we should have about 95,000 among all these 5 facilities. However, we had issues with the way data get transported because of technical issues and issues related to administrative. And currently we're waiting on the administrative issues to be resolved. The other data set we have is our Medicare data. We do request our Medicare data on a regular basis. We currently have our 2013 to 2017, and we are still waiting on our 2018 to 2019. We have paid for it, but we have not received the data yet. And this kind of on this slide describe the type of data we have. We'll have a demographic, we have chronic conditions and cost, and we do collect the diagnoses as well as the procedures. And in 2018 and 19, we actually added a file related to drug information And the reason we did this because our partners really wanted that information with our regular analysis. So we did request it, and the hope is to have it when Medicare gives us the data. We also have a crosswalk with Social Security number and names, and that allow us to link this data to other data sets. And I'll show you why this is important for us. We also have access to our hospital discharge data from our, you can see our data on OASIS, or our online analytical statistical information system, and the website is up there. It only shows Alzheimer's disease as, ICD-10 G30, and not all the other diseases. But we, as a central registry, we do have access to the raw data, and so we can do more analysis, and we can link this data to other data sets that if we wish to. We also have access to our death data, and we have done a lot of analysis using our death data, and we also have access to our raw data and not just the statistical data file. One of the main data set that we use heavily is our Georgia Behavioral Risk Factor Surveillance System. If you're not familiar with it, it is an ongoing health survey. It's a telephone survey of randomly selected households. In Georgia, we have about 8,000 respondents for adults, non-institutionalized adults 18 years and older. And since 2012, we have been adding cognitive decline module in odd years and the caregiver module in even years. And these two modules are really supported by our Division of Aging. So we conducted with the Department of Public Health, but Division of Aging pay for these modules. So some of the data we have used on some of the publication we use, and I'm glad Dr. Thorpe have mentioned we really need to use this data in different formats. So we have produced reports, long reports. We have produced short data summaries. We included both 1 year or combination of years, and we do have data in more of just data tables. Some of the data we use from Medicare, for instance, we have always provided the prevalence as it is required by our law. And we always show differences in terms of sex, gender, race, ethnicity, and comorbidities. We always show data by comorbidities, and we are able to show data by survival. And we are able, because we have name and social security, we're able to link it further with our death data and look at 1 year, 2 year, or 5 year survivors for our Medicare beneficiaries. We provided data by geographical region, and in the state of Georgia, we are divided into 18 public health districts, their administrative district, but it allow our program to better target if they would like to go to areas with a higher prevalence of patient with Alzheimer and other related dementia. So it gives them that opportunity to target a specific geographical location. We did the same with our behavioral risk factor surveillance system. In this one, like you could see, we are able as at the state to really combine the years to give us more stable rates. And the questions is really for addressing more moderate type of disease or cognitive impairment, is whatever a person, it's a person response, so it is not a physician diagnosed, but as you know, that quite a few of them will end up having or developing Alzheimer or other dementia in the future. So that's help in our planning purposes and directing our efforts in addressing cognitive impairment. So again, the data is always produced in charts, tables, pie charts, whatever mechanism that help our program in better understanding and disseminating, as well as helping them in planning purposes. We produce data again by geographical location because we are able to combine years. We can look at public health district as defined by the Georgia Department of Public Health. We're able to regroup this data because we have a county level data. We're able to regroup them by any region, such as the one you could see, our division of aging. And then in our maps, we can always do look at rural versus urban and show data and the various level of prevalences by county. We also done looking at the different questions on the cognitive impairment and the way it is answered, as you have the options always or usual, sometimes and rarely. And we could say among those with perceived cognitive impairment that 17% have said they have always or usually given up on day-to-day chores. So you can look at more severity of the perceived cognitive impairment and make decisions on where do you want to put your resources.
Also, can you wrap it up for us?
So, thank you.
Past time.
Thank you for letting me know. Also, we can look at our data by various social economic status or social determinant of health. Since the BRFS collect all this information, we can look at health access. We can look at health issues related to screenings and other comorbidities. We can also look at our caregiver, and from our caregiver module, we can look specifically at caregivers who provide care for Alzheimer patients. We can look at their health in particular, which I think that's also important for our planning activities. In our mortality, we've been looking at trends as we are expected. We could do it by various demographic distributions, as well as by county or geographical location. And in one of our analysis, we wanted to look more specifically at the trend and if the coding underlying cause of death has changed, and that could be why we are seeing a higher number of people dying with Alzheimer. So we have a data set ready, more recent data set ready. And if anyone is interested to analyze this data, we'd be happy to share. It has the underlying cause as contributing cause of death. Because we have social security numbers and names, and we have other registries under the chronic disease, health behavior, and injury epidemiology, we're able to link our data. And this is an example of linking the data with our Georgia Violent Death Reporting System. And we were looking at suicide among our dementia patients. And we could, that data really provide information on what are contributing factor for a person to end their life with suicide. And you could see from this saying that those who are diagnosed early and diagnosed within their first 12 months, they're at higher risk for dying of suicide. And the majority of these deaths are really due to firearm. So our discussions and conclusion where we really need the healthcare provider to really assess our patients when they're first diagnosed, and to really do more education related to firearm safety with the patient as well as with the caregiver. So that's kind of my talk for today, and I thank you so much for listening, and I think we take the questions at the end. Thank
That's
you.
right. Thank you so much, Rana. All right, Maggie, if you're ready, if you can share your slides.
Okay, hello everybody. My name is Maggie Miller and I am the South Carolina Alzheimer's Disease Registry Manager. And I am here to give you an overview of our registry. Okay, here we go.
There we go.
Sorry about that. So first, I would like to acknowledge the key collaborative partners who have aided in the growth and development of our registry. The South Carolina Department of Health and Human Services, South Carolina Department on Aging, the Revenue and Fiscal Affairs Office Health and Demographics Section, and the Arnold School of Public Health at the University of South Carolina, and among many others. So for this presentation, I'm going to discuss a little bit of a background about ADRD, history of the registry, our data collection procedures, a brief summary of our 2021 annual report, our data linkages that are available, some examples of research using the registry, and how to access registry data. So in 2022, an estimated 6.5 million Americans are living with Alzheimer's disease. Between 2020 and 2025, every state across the country is expected to experience an increase of at least 6.7% in the number of people with Alzheimer's. The West and Southeast are expected to experience the largest percent increase. By 2030, it's estimated that 1.1 million South Carolinians will be over the age of 65, and this represents 1 in 5 residents. With increasing age as a leading risk factor for Alzheimer's disease, South Carolina's rapidly growing population of persons aged 65 and older presents a challenge to families, communities, and those who plan to deliver services through the state. So the South Carolina Alzheimer's Disease Registry is a unique resource for statewide surveillance and research. It's an asset for community planning in both health and social services. Our registry collects data from secondary sources about individuals with Alzheimer's disease and related dementias in South Carolina. We were founded in 1988, so this is our 34th anniversary. And the registry, we use the acronym ADRD, and that's defined as Alzheimer's disease and related dementias. The term related dementias refers to dementias associated with vascular disease, mixed dementia, and other medical conditions such as Parkinson's disease. We are one of only 3 population-based state registries in the United States, and we are the oldest of the 3. We just heard from Rana about the Georgia registry, and we'll hear from the West Virginia registry in the following presentation. So a quality that makes our registry unique is its legislation. In 1990, the governor signed a law authorizing the establishment of a voluntary statewide Alzheimer's disease registry. The law has strict confidentiality requirements for data collection, but it does allow registry staff to contact the families and physicians of persons diagnosed with ADRD to collect more in-depth data, such as information related to the progression and treatment of the disease, service utilization, and caregiver characteristics. So the goals of our registry are to provide disease prevalence estimates to advise and enable better planning for healthcare providers, patients, and decision makers in social and medical services, to identify differences in disease prevalence among demographic groups, to help formal and informal caregivers who provide care for individuals with ADRD, and to foster research into risk factors for ADRD. So our registry uses data from a wide variety of sources to capture as many diagnoses as possible. We collect data from hospital records, ER visits, Medicaid claims, the Department of Mental Health, home health, vital records, the state health plan, community mental health centers, mental health and rehabilitation clinics, community long-term care data, and the Program for All-Inclusive Care for the Elderly, PACE, as well as a few geriatric primary care practices. All of these data sources are combined in the Health and Demographics section of the Revenue and Fiscal Affairs Office, where they're stripped of any identifying information and given a unique identifier. Then any duplicate records are removed, and the result is our registry. So to be included in the registry, individuals must have a diagnosis of ADRD. The physician's diagnosis is collected from individuals' medical records or insurance claim data using ICD-9 and ICD-10 coding. An individual is then classified into 4 general categories for reporting purposes. These include Alzheimer's disease, vascular dementia, and mixed dementia, which has an indication of both Alzheimer's and vascular on their medical record. Those classified with dementia in the other category are other diagnoses distinct from Alzheimer's disease and vascular dementia. These include, but are not limited to, alcohol dementia, Parkinson's disease, and dementia with Lewy bodies. Other disorders such as organic brain syndrome and HIV must have another dementia code present to be included in the registry. Our registry contains information related to diagnosis, such as types of dementia and data source in which they are identified. So if they were identified in the emergency room, the hospital, or through state health plan, and other sources as well. We also have demographic data, including age, race, gender, and whether they are currently living or have passed away. We have location variables, including where they were residing at the time of diagnosis, and that could be in the community or in a nursing facility. And also location within the state, so county level and a zip code level data as well. So here I'd like to share an overview of this year's registry annual report. This year we're presenting data from 2017, which is the most current year of clean and validity check data that we have available from all of our data sources. In 2017, we maintain information on over 111,000 individuals living with Alzheimer's disease and related dementias in South Carolina. When combined with census data, our registry shows that 11% of South Carolinians aged 65 and over have ADRD, and 51% of those 85 and over have the disease. 62% are women, and African Americans are at a notably higher risk of an ADRD diagnosis, being 45% more likely to have ADRD than whites in South Carolina. So here is the prevalence of ADRD for individuals 50 and over by county. The prevalence does vary by region, and it ranges from about 3% to 7.2% in each county. There seems to be clustering of counties with higher prevalence in the northwestern part of the state, including Spartanburg, Union, Greenwood, and Abbeville counties. In the northeastern area, including Lee, Marion, Marlborough, Florence, Sumter, and Williamsburg counties. And then down in the southern part of the state, where the highest prevalence are in Allendale, Hampton, and Jasper. One great benefit of having population level diagnosis data is the ability to create maps like this so we can highlight where the areas of the greatest service needs lie throughout the state. So our registry cases are classified into 4 general categories shown here. 73% of registry cases have an Alzheimer's disease diagnosis. 9% have vascular dementia, which occurs most commonly from blood vessel blockage or damage leading to infarcts or bleeding in the brain. 3% had both Alzheimer's disease and vascular dementia, which is our mixed dementia category. And 16% were diagnosed with a dementia related to other medical conditions. So the dementias in other medical conditions are listed here on the slide. There are 14 different dementia-related conditions that make up 16% of our registry. There are other cerebral degenerations and dementia with other conditions are non-specific dementia diagnoses that are the most commonly reported. Then the next most frequent diagnosis is dementia with Lewy bodies. Then we see alcohol dementia, Parkinson's, frontotemporal, HIV/AIDS dementia, organic brain syndrome, and so on. Over the past few years, we have seen an uptick in alcohol dementia and frontotemporal dementia. So we are going to continue to monitor that. going forward. When looking at data by race, we see that there are 61% white cases, 24% are African American, and 14% are other races or unknown. And we have less than 1% Hispanic in our registry. Although there are more whites living with ADRD, African Americans are at a notably higher risk, as we mentioned previously. Studies have found that the differences in risk for ADRD can be partly explained by disparities in health conditions, socioeconomics, and life experience of the older African American population compared to the older white population. And a lot of this was discussed in Dr. Thorpe's talk earlier today, which was very informative. The registry also identifies where the person was living at the time of diagnosis. And as you can see in this chart, Hispanics and African Americans are commonly living in the community when they are diagnosed with ADRD. This includes 84% of Hispanics and 75% of African Americans. Almost a third of white ADRD cases are living in a nursing facility at the time of diagnosis. So through our relationship with the Health and Demographics section at the Revenue Fiscal Affairs Office, we are able to link our registry to various other statewide data sources. And as you can see in this graphic here on the slide, we are able to link to 21 data sources. These can provide more information about ER visits, hospitalizations, behavioral health services, and social services, among many others. The availability of the data does vary by source, and release of information is under the control of the originating entity, and each of them has their own application process. So here are some examples of registry-related research using the linkages that I mentioned on the previous slide. We have investigated behavioral disturbances and nursing home placement of individuals with Alzheimer's disease using in-depth caregiver interviews. We've also looked at past history of driving under the influence and its relationship to AD. We've done mapping studies using GIS, looking at the association between neighborhood characteristics and Alzheimer's disease and related dementias. We've looked at sedentary behavior in Alzheimer's disease caregivers, and these caregivers were given an accelerometer, and they wore it for a week, and it recorded their activity levels. One of our recent CADMR scientists investigated health disparities in HIV-associated dementia. And later in the conference, you'll be hearing from two other CADMR scientists and the work they have done using the registry. So for anyone who is interested in accessing registry data, we have an electronic application. You can either visit the Office for the Study of Aging website or search the Alzheimer's Disease Registry by using the search option in the University of South Carolina homepage. This here on the slide is a snapshot of our registry website. And if you look on the right-hand side of the page, directly underneath the link to our annual report, you'll see a section titled For Researchers. And here there's a link to request access to registry data. You'll just need to click on the link that is circled there with the big red arrow, and that will bring you to access the application. So if you're interested in requesting data, if you would like a copy of our annual report, or if you would like to learn more about the registry, you can feel free to contact me, and my information is here on the slide. Thank you very much for your time.
Fantastic. Thank you, Maggie. And now we're actually going to show Dr. Schur's pre-recorded video. So bear with us and we're going to share screen. Thank you.
Hello, my name is Bernie Shrews, and I'm the director of the West Virginia Alzheimer's Disease Registry. Today, I want to tell you a little about the registry, what it is, why we started it, and how we go about collecting the data and the pitfalls we've encountered along the way. The West Virginia Alzheimer's Disease Registry is a state-based registry of people in West Virginia with Alzheimer's disease or a related dementia. It's a population-based registry rather than a patient registry. Patient registries are designed to recruit patients who actively participate in data collection, including physical exams, cognitive assessments, imaging, sample collection, clinical trials, and they may even donate their bodies after their demise. A state-based registry, such as the West Virginia Alzheimer's Disease Registry, does not require the person to do anything and is designed to passively collect information about the incidence and prevalence of Alzheimer's and related dementias in order to provide information to stakeholders, including the patients themselves, their families, healthcare providers, and decision makers at local and state levels. Other than the summary data, the registry is not accessible to the public, and the database itself is password protected and kept on servers in a secure facility. The West Virginia Alzheimer's Disease Registry was modeled after the state-based registry in South Carolina. When we first started thinking about a registry, their then director, Carol Kornman, provided us with expertise, advice, and a copy of the legislation used to establish their registry, which we used to propose legislation to the West Virginia legislature. When it was finally approved and became law, a major difference between the two registries was that the West Virginia legislation said that, quote, all healthcare providers shall report, unquote, cases of Alzheimer's disease and related dementias to the registry. We'll see later how that has affected the way we collect information. A major reason for starting the West Virginia Alzheimer's Disease Registry, or registry for short, was to provide an estimate of how many people in West Virginia had dementia. There are a large number of factors that suggested published estimates of dementia in West Virginia were significantly short of the mark. West Virginia has the third oldest population in the nation, and we know that age is a good predictor of those who will develop dementia, with 1 in 10 at age 65 developing Alzheimer's, and 1 in 3 by the time people are in their 80s. The Alzheimer's Association has published estimates of about 38,000 people in West Virginia having Alzheimer's or related dementia. But looking at West Virginia Medicare claims for 2018, which is a good proxy because it covers over 95% of those over age 65, suggests that there are many more, over 44,000 with a diagnosis or being treated for dementia. And these numbers may be just the tip of the iceberg. There are many older people who do not see a doctor at all or not very often, and may not have even been diagnosed. The situation in West Virginia and many other areas of Appalachia is further exacerbated by a host of issues, including age, health disparities, citizens having many chronic conditions, including risk factors for Alzheimer's, such as diabetes, obesity, high blood pressure, and heart disease. Compared to the national average, West Virginians are poorer, more rural, underemployed, and less well educated. Although we have several major hospitals, medical access at the local level is still limited. Finally, at the state level, things need to be improved to provide much needed resources. Now, what about the data we collect? Data about incidence and prevalence of Alzheimer's disease and related dementias are based on private health information about people who have dementia. Because this is a population-based registry covered by state law, it is a public health activity and meets the requirements for a HIPAA exception. Our data sources include the healthcare providers, hospital records, nursing homes, Medicare and Medicaid data, and vital records. As you can see from this pie chart, the major source for records in the registry is from Medicare files, which is where we turned when other records were not available or could not be obtained from healthcare providers. Despite reporting being mandated by state law, obtaining information from healthcare providers proved to be an insurmountable problem, despite numerous attempts to get the information about the registry to them, including multiple presentations at local, regional, and state provider conferences, mailings, presentations to their office managers, and other ways of reaching out to the healthcare providers. It turns out healthcare providers don't like to be told what to do. Who knew? In order to understand their issues, we finally asked them. The West Virginia Practice-Based Network is a group of over 100 primary care entities throughout the state that try to improve clinical practice based on research. We designed a questionnaire as part of the annual West Virginia Practice-Based Research Network Survey, WVPBRN for short, to find out about their experiences with cognitive impairment and dementia in the healthcare practices. There were 72 practices who responded to the cognitive impairment questions on the annual survey. These respondents care for more than 120,000 patients. We asked a range of questions about cognitive impairment in general, as well as more specific questions about the registry. We asked practices to estimate the percentage of patients in their practice who had cognitive impairment and how they detected it. As you can see from this first graph, practices estimated that between 10 and 40% of patients had some form of cognitive impairment. The one practice with 40% of their patients was a geriatric practice. This was determined by several means, how they determined cognitive impairment. Clinical judgment, 39 practices said they used clinical judgment, 33 said they used cognitive tests or cognitive screens, 26 said they also used caretaker input, and 11 said they used some form of imaging data, PET or MRI. Now, it's important to note that these were choices, they weren't exclusive, so many of these practices probably used one or more of these ways of determining a form of cognitive impairment. We also asked them to estimate how important concerns about cognitive impairment were for their patients. As you can see from the next chart or graph, the vast majority said it was important or very important to their patients. When asked what these practices needed to help their patients, they suggested they needed reliable information about cognitive impairment and dementia, training in cognitive assessment, consultations from a specialist like a neuropsychologist, information about social services, and information about long-term care facilities. We then asked them about how likely it would be that they would register patients in the West Virginia Alzheimer's Disease Registry. As you can see, the vast majority were unlikely or only somewhat likely to register their patients. When asked why, they said a number of different things. There was a lack of information. They lacked the time to do it. They lacked the personnel to conduct the screen. There was a lack of reimbursement for their time, and some practices saw very little, if any, benefit. Fortunately, the care for dementia landscape has changed significantly since we first began the registry. Project ECHO is an example. It's a guided practice model of medical education in a hub and spoke knowledge sharing type of network led by expert teams who use multi-point video conferencing to conduct virtual clinics with community providers. So this is a peer-to-peer type of arrangement. De-identified case presentations will be given by the primary care providers out in the field, and experts review them and provide basic recommendations. Of significance here, as you can see in the red rectangle, sessions on memory health and cognitive impairment. Another major change in West Virginia was brought about by the West Virginia Rockefeller Neurosciences Institute. It used to take people up to 6 months to be able to see a memory specialist in West Virginia. As a result of these shortcomings, the Rockefeller Neuroscience Institute has established and runs a multidisciplinary memory clinic where patients can be seen within days or weeks rather than months. With the data that we generated from the West Virginia Alzheimer's Disease Registries, volunteer advocates with the Alzheimer's Association West Virginia chapter have organized awareness campaigns lobbying state legislators in the House and Senate about the impact of Alzheimer's and related dementias in the state, focusing on their own electoral districts. One of these major lobbying efforts resulted in providing dementia training for police officers. And so you can see that despite some of the issues that we've had in collecting data from physicians, the net result of the West Virginia Alzheimer's Registry to date is a database of over 28,000 individuals with private health information. Since we started, Project ECHO has been initiated with training and consultancy. And the Rockefeller Neuroscience Institute now has a memory clinic where it used to take 6 months, it now takes days or just weeks for an appointment. And as I've mentioned, the Alzheimer's Association voluntary advocacy has provided results in the form of police training. So that, in a nutshell, is the West Virginia Alzheimer's Disease Registry. I'm sorry I can't be there in person, but if you'd like to ask questions or have comments, please contact me at bshrews@hscwvu.edu. Thank you so very much.
Fantastic. So thank you very much to all three of our panelists today. And thanks for enlightening us on the different nuances of each registry. So we do have several questions. And so this is also a reminder, we have about 10 minutes for questions for this session before our break. And so I'll start. We do have a few questions already on deck. So thank you to those of you who have entered those into the Q&A feature. So first question came during Rana, your presentation. Can you tell us what HL7 is?
So HL7 is abbreviation for Health Record 7th version. It is a mechanism to extract data from the electronic health record and get the data reported electronically to the central registry. So it helped the healthcare provider to report the data without them actively entering data into a system. It's just extracted and submitted to the central registry.
Great, thank you, Rana. Question for you, Maggie. Attendee says that you mentioned the fact that they're curious about is the 6.7% increase in the number of people with AD due to the baby boomer generation?
Well, I actually got those statistics from the 2021 Alzheimer's Association Facts and Figures report, and they do projections for every state. And basically the projected increases are based in changes over time in the age compositions of the states. So it is really focused on the increase in numbers of individuals 65 and over.
Thank you. And I wonder if there are similar phenomenon around, as we increase the general population's knowledge about ADRD, perhaps that can be an indicator as well, or something to impact that.
Absolutely, yes.
Perhaps another question for you, Maggie. Does ADRD also address people with memory loss due to open heart surgery?
Well, within our registry, we capture anyone who has a diagnosis of dementia. Now, we are able to link back to other records that could show a history of open heart disease. So if the person who asked this question is interested, we could do some data analysis and actually look at individuals that have had open heart surgery, a history of open heart surgery, and see if they do tend to develop ADRD in the future.
Okay, thank you for that. A question for either you or Rana. Where different populations are diagnosed with ADRD seems to directly correlate to cultural norms in respect to caring for elders versus placing care outside of the home. Any thoughts about that?
I can address that quickly, and they are exactly spot on. It is definitely a cultural norm in the African American population and Hispanic population to care for their loved ones at home for as long as they can. We've actually done studies that looked at nursing home placement, and we compared whites and African Americans. And so we had individuals who were considered our cases were the ones that were placed in a nursing home, and others that were in a community. Now they were both nursing home level of care, so the individuals in the community could have been in a nursing home. But in that study, we had to oversample to find more African Americans that actually placed their loved one in a nursing home. So I think, basically it's your culture plays a huge role in terms of where your loved one is placed.
Thank you. And then we have an attendee who added the Asian population as well. Be one of those
Yes.
groups to add to that description. Rana, do you have any thoughts about that?
So we haven't done the analysis in that from that perspective, but from our behavioral risk factor surveillance, we know that the majority of the caregivers are given at home and for relatives, and we know that for some reason, the caregivers tend to be taking care of a white, non-Hispanic white patient with Alzheimer. But when you look at the kind of the distribution, it looks very similar to the distribution of the Georgia population in terms of caregivers and who they take care of. In terms of race, ethnicity. So we would need to do more investigation in that. Our central registry database, both of them, both the HL7 and or the portal are not mature enough or do not have good data yet to be able to do what South Carolina has done, but these are variables that we collect in the central registry.
Great, thank you so much. Okay, Daniela says, I'm most familiar with the South Carolina registry. How is the registry promoted elsewhere?
So
the Georgia registry, yes. Thanks, Rana.
Yeah. So in Georgia, we actually work with our group, the guards group, and our program to talk about the registry. We don't really expand or talk too much about it because of the reason we're still trying to get the data reported electronically. We'd rather go electronic than to go toward the physician entering the data into the portal. And so we just have that system going as of 2021, and COVID hit us. But the plan is to really advertise through our collaborators and partners and stakeholders about reporting using the electronic system.
Great, thank you. Still have about 4 more minutes in this session. If anyone has any questions.
I have a question for Rana.
Oh, go ahead, Maggie.
So Rana, in your presentation, you mentioned having access to Medicare data. And that's one data source that we would like to also obtain access to. And I know you had mentioned, your legislation allows a certain level of funding for the registry. Do you have long-term funding set up and access to Medicare data in terms of, over a long period of time, or was this just a one-time access of Medicare data?
Thank you, Maggie. No, we do use the state funding to support a person and purchasing of the Medicare data.
Okay.
So the hope is in the future, as Medicare getting more expensive, the hope is we get additional fund from the legislator to continue purchasing the data.
Okay, that makes sense.
And we actually realized we lost our epidemiologist, and we're having difficulty finding a new one. but we had the opportunity to purchase the data with the, because we had additional unused fund. So we purchased the drug data, which is the most expensive piece of it.
Okay. Okay, thank you. Thank you, Rana.
Thank you for
Great
that
presentation.
question, Maggie. We
You're
have a
welcome.
couple more questions that have been viewed in our Q&A feature. First question, do any of the data sources include information on sexuality of those diagnosed with ADRD or their caregivers? This person is interested in studying sexual and gender minorities in particular.
So in Georgia, on the BRFS, if you're interested in using the behavioral risk factor surveillance system, then sexual orientation is available, and we do oversample our LGBTQ population, so we are able to analyze with other modules. The central registry does not collect sexual orientation.
Yes, in South Carolina, within our registry, we do not capture sexual orientation information. That would have to be captured through interview or actually contacting the individuals. But in terms of pulling from a source that we have, that information is not available, unfortunately.
Great, and we have one more minute, but I think we can answer this question quickly. Because the South Carolina registry is voluntary, is there an estimate of underreporting?
That is a very good question. So it is our registry is voluntary in terms of people don't elect to be entered into the registry, but we pull from medical records and claims data. So any sort of hospital medical encounter is captured. And so we are able to pull those diagnoses from those encounters. So we do capture of the majority of diagnoses. Now, we have looked into possibly missing individuals that seek healthcare across borders. So, you know, especially within the area around Beaufort, we have found out that a lot of people seek services in Georgia or even Florida. Some people in the northern part of the state might go to Charlotte. And so we may be missing individuals that are actually residents of South Carolina, but seeking services outside of the state. Now, another area where we could possibly be missing individuals is veterans. We would love to have VA data, but we currently have not been able to set up that, that connection. But there's a possibility of veterans and then also individuals that cross borders to access healthcare.
I would agree with Maggie, knowing working on other central registry in the state of Georgia. We do lose patient for other state and we do gain patient from another state, but those need a interstate agreements to share this data among each other, and that doesn't exist now. When we look at our reporting from the 5 MAGs that we have, we do subset it for Georgia resident, and we do have some non-resident that's being reported for us. So we kind of put those on the side. We don't use them.
Yes, we capture that information as well. We exclude those individuals that have an address outside of South Carolina.
Fantastic. Thank you both, including Bernie. Thank you all for your presentations today. I certainly learn every time I hear you, Maggie, and also Ron, I've heard you a few times describe the expansive data that's available in the registries. It really is great, and I learn something new every time. And Dr. Thorpe mentioned how our colleagues in cancer have done a really great job of utilizing these types of data. And so we certainly hope that this conference is a great introduction to many people who before now perhaps didn't know about access to these data. So thank you very much. So now we will have a brief break. Do be sure to return at 11:45, at which time Drs. Nicole Davis and Miriam Evans will be our speakers for session number 3, where they will discuss the research that they have conducted using South Carolina Alzheimer's disease registry data. Thank you very much. 15 minutes.